Today, we're continuing the Aging Gracefully series, and we're pleased to have Mary Bowman and Michael Bolewitz, did I say it right? To discuss healthcare decisions and share insights into the gift of hospice care. Next week, Chuck Williamson and certified financial planner Kelly Graves will explore legal and financial dimensions of stewardship at the end of life. Take it away, Mary.
Good morning, everybody. It's so nice to be with you all. I am not going to take too much time. I'm really just going to kick it right off to Michael and let him introduce himself, because I think that's part of the story. He is the current COO at VIA Partners, and he's going to kind of tell you that story, and we're going to dive into hospice for a little bit and palliative care and also some advanced directives, and I'm going to let Michael begin.
Well, thank you. Good morning, everyone. Great to be here. Nice to meet everyone. See some familiar faces.
Michael, can you turn your mic on?
Oh, yeah. See, I already messed up. Yeah, how's that? Better?
That's good. Perfect.
And so, so my name is Michael Bolewitz. I'm a pharmacist by training. And so this is, if you would have told me coming out of pharmacy school 25 years ago that I'd end up in hospice, I'd be like, you're crazy. But it has been an unbelievable, career. And so I've been with VIA Partners now for 18 years. And I actually started as the first clinical pharmacist there, but have been in the COO role for 13 of the last 18 years. And so a lot of the clinical teams kind of roll up to me. And I don't usually do a ton of presentations about hospice and palliative care, but I know enough to be dangerous now at this point, so I'm going to share what I know with you all. And I think I'd like to start out with a little bit of a joke. It's a joke, but it's serious. But the U.S. government decades ago did this longitudinal study, recruited thousands of Americans, all kinds of backgrounds, socioeconomic, race, religion, everything. Followed these folks for 20 plus years and spent billions of dollars doing it. And they determined that 1 in 1 Americans will eventually die. And it's not something that, death is something that's always kind of funny to talk about. It's very much a part of life though. And when we get to the point, well, I should ask, I'd like to ask folks, how many of you all have advanced directives in place? How many of you have a will in place? How many of you have a healthcare power of attorney in place? You guys are ahead of the crowd here. You all should be teaching this class, but death is something that, again, it happens, and sometimes it happens suddenly, sometimes it happens over a long period of time. And, hospice used to be something that was, when you thought about hospice 30, 40 years ago, you thought about cancer. That was the primary reason why folks got into hospice. And I'll tell you now, in today's world, cancer is probably 25% of our patient population. Most patients that we care for in hospice, and this isn't just for my organization, but really across the country, have some type of chronic illness, whether that's heart disease, COPD, dementia, other things that really people live with now for years. And so it becomes a lot less predictable about, typically, again, hospice is a 6-month or less benefit, right? And so it becomes a little less predictable about when is the last 6 months of life. Cancer, you've got a pretty good trajectory that most people follow. So, but let's start with the basics. So how many of you all have heard of palliative care? Okay, so palliative care and hospice are very similar, but not exactly the same thing. So my old chief medical officer used to tell me, his analogy was, all hospices are a type of palliative care, but not all palliative care is hospice. And he used the analogy of like Not all Buicks are GMs, or all Buicks are GM vehicles, but not all GM vehicles are Buicks. And so when we think about the difference between hospice and palliative care, oh, I went the wrong way, sorry. This chart I think is very helpful. Hospice is a very well-defined, regulatorily kind of statute-driven benefit under Medicare. And a lot of commercial insurances and other folks now have a hospice benefit as well. But in order to qualify for hospice, you have to have a physician certify that you have a life expectancy of 6 months or less. And so you don't need a physician order necessarily to get hospice care. We have lots of people call, family members call, neighbors call, I'm concerned about my neighbor, I want to talk about my mom. You don't need a physician order necessarily to enroll in hospice care, but you do need our physician to sign off that you, after they reviewed kind of the documentation, that you have a prognosis of 6 months or less. And so again, hospice has a lot of regulations around it. It was a benefit created back in, I think, the 70s, early 80s. It's not changed a whole lot, surprisingly, over the years. And just talking a little bit about the type of healthcare we're in today, you hear a lot of talk about like value-based care, where folks are kind of charged with managing the entire care of a person, from psychosocial aspects to not just the medical, but broader. And hospice was really kind of the first foray into that type of medicine. So hospice provides not only a physician, but you've got nurses that come out, you've got social workers, you've got chaplains, we've got volunteers, we've got pharmacists now, we've got all kinds of folks that are all around the patient supporting that end of life care journey. And so every 2 weeks, the team comes together and reviews what's going on with this patient, what else do we need to be thinking about, and how are we preparing you for the next 2 weeks. And so hospice, I think the other thing that folks think about with hospice is you think about a place, but typically hospice is delivered in the home. So for example, right now we have almost 2,000 hospice patients under care between North and South Carolina. 99% of those patients are either in a nursing home, an assisted living, or their own personal home. Very few people are in our hospice houses. And I don't know how many of you are familiar with the hospice houses here in town, but we have 3 here in Mecklenburg County: Southminster, Huntersville, Aldersgate, and we have some others across in Shelby, North Carolina, and down in South Carolina. But the point here is that hospice care is mostly delivered in the home, and where patients call home. And sometimes also folks think that hospice is about when you come under hospice care, all we do is give you morphine and Ativan and it's going to be over very quickly. That is not what hospice is about, although we do use a lot of morphine and Ativan, to be honest, because they work. But typically, patients, depending on their diagnosis, can live for 6, 12, 18 months, although you have to have an expectancy of 6 months or less. We have plenty of patients who live past 6 months in hospice care. And I'll tell you, the number one thing that we hear from family members and patients is that I wish I knew about hospice sooner. Because what happens is typically when things are going on and the need for hospice is a little bit more pronounced, we get involved and things kind of calm down. And you get some nursing support to come out to your home. We clean up your medication list. As a pharmacist, I'll tell you, I was telling someone else earlier today, it's a lot easier to talk people into starting the medication versus stopping the medication. Oh, my doctor has told me I have to take this forever, never stop this. But when you're in hospice care, it's really about what's the benefit burden profile of that medication. And I'll tell you, when we've cleaned up medication lists for patients and you stop some of the things that people have been taking for a long time, it's amazing. Sometimes pick up a little bit. The clarity comes back. You have fewer side effects from the medications that you thought didn't have any side effects. And that alone is a huge help. But you've got this team of people now coming into your home, right? You've got a nursing assistant helping with the bath or helping with some homemaking kind of chores. You've got social workers who are helping with resources you'll probably hear about next week. There's just a lot of, we call it the hospice hover, when people first enroll in hospice and things tend to calm down. And then, as I said, folks are like, this is not what I expected at all. This is so much better than what I ever anticipated hospice to be. Hospice is a scary word for a lot of folks. It's intimidating, if there's some finality associated with it, right? And so sometimes a lot of folks start with palliative care, which we'll talk about in a minute. But hospice, again, is the thing that most people think about when you think about end of life care. So again, there's some other details there, but billing wise, you get under Medicare Part A. If you've got a Medicare Advantage plan, interesting enough, if you ever elect hospice, your loved one needs hospice, it does revert back to traditional Medicare. And so it doesn't impact your Medicare Advantage plans. And the other thing that people don't, I think, sometimes realize is that when you enroll in hospice, in theory, the hospice is now in charge of all of the care. So that means we're providing medications, we're paying for the durable medical equipment, which is what DME stands for. We pay for the supplies. We do all of those things that are needed to support care in the home. And so even the prescriptions that you're on, that the patient's on, are paid for by hospice. And so it's a wonderful benefit. And when I led off with the whole idea of value-based care, like hospice was the original value-based care bundle, because we cover everything. We're responsible for everything, all aspects of care. Palliative care, on the other hand, is typically, now hospice is well defined. Palliative care is a little bit more of a wild, wild west. There's not like a definitive Medicare benefit for palliative care. But this is the way that we define it. And I think there's some similarities kind of across the country, but typically palliative care is associated with folks who have a limited life expectancy. So I'll show a graph on the next one of these slides coming up, but palliative care you can have at any point in time. And we have children who have been born with, some kind of life-limiting issue. They have palliative care from the day they're born. They're not dying technically, but they need some kind of support. And so palliative care fits that model. The way palliative medicine is delivered is typically through nurse practitioner provider visits, and that's all billed through Part B. But you're not in a care model with palliative care like you are with hospice. It's more consultative, whereas hospice is kind of a whole experience with the healthcare team. And so there's no coverage of medications, DME, supplies, all of those things with palliative care. So any questions, and please feel free as I'm talking, if you've got a question or comment, raise your hand. I'm happy to engage in conversation about this. Oh, sorry.
So my thought is the difference between, so with palliative care, for example, I had a coworker of mine, she had breast cancer, she went into remission, and then I think the cancer came back into her neck. And so she was more palliative care.
Yeah.
Whereas my mother had dementia for a long time, and towards the end of her life, she was in hospice. So I think of it as being a slightly different timeline. Does that make sense?
Yeah, exactly. With prognosis wise, it's really the longer prognosis, more associated with palliative care, the shorter the prognosis, more associated with hospice care. And so, again, palliative care is more consultative in approach. And so typically what our clinicians do, we'll get consults for palliative care. And sometimes the biggest thing with palliative care that we do is typically symptom management. So let's say you've got cancer or COPD, you're having some shortness of breath. typically a lot of specialists aren't taught how to dose opioids and other things very well. And so they'll make a referral to palliative care. And our palliative care practitioners will be the ones who prescribe a lot of the symptom management drugs in consultation with your attending or with your specialist. And so that's a very common route that people get exposed to palliative care, is because they have a symptom management need. You're not dying, but you've got a symptom management issue. Or we're just struggling with, the team may be struggling with getting the family or the patient and the patient's decision makers together on what are the goals of care here. And so our palliative care teams are pretty good at pulling folks together and having family meetings or having discussions around where are we going, what kind of advanced care planning do we want to engage in, who's the decision makers, who do we communicate through, and really trying to coordinate the care and help streamline some things. And so you can have palliative care typically at any point in time when you are diagnosed with anything that is of significance or a kind of a life-limiting situation. Palliative care should really start. And so this is the graph that I was talking about. So if you follow along the bottom there, you're talking about disease progression, right? So at the bottom left, thinking about when you are diagnosed with a life-limiting illness or a chronic illness. Really, as soon as that starts, or as soon as that is identified, you could have a need or benefit from palliative care consultations. All of the things we talked about. Who's your decision maker? What is your advanced care plans? What kind of symptoms may you be having? But, early on, the focus of any treatment is really around life prolongation or even cure. As we progress over time and the disease progresses, right, the focus on cure or on life prolonging treatments starts to decrease, and the focus on palliative care and symptom management and comfort increases. And then you get to the point where you become eligible for hospice, 6 months or less, have hospice care, hopefully for the full 6 months, if not longer. And then after the death of a patient, hospices are required to offer bereavement services to the family for 13 months after the death of a loved one. And so this is kind of a very simplistic picture of how does a diagnosis of a severe disease fit with when is it appropriate for palliative care, when is it appropriate for hospice, and what happens after death with the hospice care. Any questions on that?
The recommendations for both of these typically come from the treating physician or from patient.
Yeah, most referrals come from a physician. But I will tell you, our goal and most folks' goal is to, throughout this course of care and disease progression, one of the major goals is to keep people from going to the hospital. I don't know how many of you have been to the emergency department lately. You don't have to answer that. But it's not the greatest experience, right? You sit there for hours, you wait, it's uncomfortable, your patients are in and out. And when you're admitted to the hospital too, it's not only a costly endeavor to be admitted into the hospital, but it's also, depending on what your goals are and how you want to be treated, sometimes those things don't always align. And so one of the big things for us is really focused on keeping patients in the home for as long as possible, as much of the time as possible. Nobody enjoys an ambulance ride. The ED process is not the most fun. Being in the hospital is never a pleasant experience. And so if we can keep folks in the home and get ahead of those issues before there's a symptom management exacerbation, or before, preventing falls, preventing other things, that's really the goal of a lot of palliative care as well as hospice.
Oh, I'm curious, how would you assess doctors' ability to prioritize something like palliative care or hospice? Or how often does it need sometimes a nudge from someone else?
Yeah, that's a great question. And there have been studies done on this. This one's not a joke. There have been studies done on this, and you would think the more intimately a physician knows you, or that you've worked, the longer you've worked with a physician, the better they'd be at prognostication. The truth is, there are some that are very good, but the truth is it's often better by a third party that has never met you before, that looks at the situation objectively and looking at the records and saying, this person needs a palliative care consult, or this person's really eligible for hospice. Because there's that human piece too of, if physicians aren't trained to necessarily, they're not trained to necessarily stop offering treatment. You know, the goal of a physician is to continue to go as long as possible. Sometimes that's not what the patient wants, and sometimes that's not what is most appropriate. But folks are the older generations in particular are usually pretty wired to listen to whatever your physician tells you to do. And so to your question about third parties, loved ones, others asking, would we benefit from a palliative care consult here? It can be very helpful. Again, sometimes being a little bit removed from the situation helps you identify the need.
I'm just gonna jump in and say that, I think so often we do defer to our doctors, and maybe it's a little bit like the parent who can't see how much their own child has grown, but it takes someone else to come in and say, wow, when did you shift in this way? And so as ministers, we often try to nudge people to think early about this. I mean, the way Michael's describing it, it's an incredible resource. And I think I startled one of our members when she came to me and she said, they're offering hospice for my mom. And I said, oh, that's great. And it sounds probably terrible, but I knew the care that the mom would be getting. And so I recognize that it does mark a point where perhaps we're approaching an end, but it's just so valuable. So don't hesitate in these situations to really be mindful of the earliest opportunity to bring in resources like this.
So just to clarify, it is appropriate for a family member to contact you and say, I think my
Absolutely.
loved one could benefit, and
Yeah.
come out, so you just do an assessment and then you say, yes, we'd love to pursue, or she's not quite ready yet, call us.
Yeah.
Okay, so that's
Yeah.
very appropriate. That happens.
Very appropriate. We got most of our referrals come from a physician, but there's a healthy amount that come from loved ones. And we can always send a nurse practitioner out to do a palliative care consult one time. It's a copay, as you would normally see any other physician, whatever your copay is. Or if you truly think that person may be eligible for hospice, our process is, and every hospice operates a little differently, but I can tell you our process would be to send a nurse out, review the records, talk to you, see what's going on, call our physician and say, what do you think? Are they eligible for hospice? And, a lot of people think you have to have a physician referral to get into either one of these programs, and you don't.
Reading a book right now, I really recommend In the Gaps. It's about medical care for our homeless population.
Mm-hmm.
How do you interact in those
Yeah.
places, palliative and hospice?
Yeah. So I'll tell you, might be a little off topic, but hospice used to be almost every hospice in this country used to be a nonprofit organization. I can tell you that's not the case anymore. It's about 30% of hospices are nonprofit now nationwide. A lot of PE money. And the reason is the way hospice is reimbursed by Medicare is a daily rate. And so every day that a patient's under care, that's how we get paid. And why I bring that up in relation to your question is because for us, ability to pay is not a barrier to getting our care. If you're eligible, we will take care of you. Not every hospice operates that way. And so for us, for example, we've served patients in homeless shelters, living out of motels, living really kind of under a bridge, and we meet them. So the staff that we have that go to do these things are incredible people. But what I'm also saying is that's why I think it's very important to support a local nonprofit hospice, because they do take care of folks like that may not have ability to pay for services.
Two comments. My mother was in 97 and she was in hospice care.
for 3 years, and they
Yeah.
took her off for 6 months at
Yeah.
one point. She started in, January 2021 in the middle of COVID still. And we actually experienced two different hospice organizations, and it's extremely different. The first was also during COVID, which they weren't even allowed into her care facility. So it was just a nightmare.
Yeah.
But what I'm saying is that the end of the last almost year was a phenomenal experience for our family. But there are differences in organizations.
Very much so.
And so this was in Atlanta, so I had no experience with what's in Charlotte.
Yeah.
But there's a fit. I mean, I felt like maybe it was part of it was a fit with our
Yeah.
families. I can say that the work was phenomenal for my moms. The last year, it's the second organization.
Yeah. And North Carolina is a it's a high quality healthcare state for a lot of things, hospice included. But to your question, which is it's a great point. You would think a lot of people would be like, because again, a physician has to certify and continually certify that a patient, if things continue in the typical fashion, would have a prognosis of 6 months or less to standard care. And so you would think if a physician's like, I think you've got more than 6 months to live, like people would be like, great, that's great. People get mad when they get discharged from hospice, because they're like, well, no nurse is going to come out here anymore. Who's going to pay for my medications? Like you were actively taking away support from me, and people get upset about that. But it happens where people get discharged. We call it discharge live. Typically, we would try to pick those patients up with palliative care to kind of track them and see if there's any further decline, and we can get us back to hospice quickly. But it's amazing when you say you're no longer eligible for hospice, and folks are like, no, I want to be eligible for hospice. I want to keep this. And you had a question as well.
So there's no private pay part of this. It's all come where you collect some private dollars.
Yeah, if you did not have insurance, we have a sliding scale, and most people would qualify for the subsidy. And I mean, we have to bill people, but we have never sent anybody to collections or done anything like that. But yeah, if you don't have insurance, there's a private pay rate, if you will.
Just curious, what is the cost per day?
Every part of the state's a little different. Every part of the country's a little different based off. So there's a percentage of the rate that is set by Medicare, and then there's a percentage of the rate that is determined by the wage. It's called the wage index. So in North Carolina, it's about $200 a day to take care of a patient in hospice for us. That's rough ballpark.
And Medicaid doesn't come into play in that for your poorer patients.
Medicaid does cover hospice as well.
Okay.
And it's usually the same payment rate as Medicare. They usually equal it, match it.
Now, is the Medicare payment fair for hospice? Because I see when I look at a bill, I can't believe this is how much I charge, this is how much I got.
Yeah. So if you have so this is interesting, but where the most expensive part of caring for a patient in hospice occurs is right at the start of care, when you're sending in a lot of support and nurses and everybody to kind of assess and get them set up for care. You start paying for a lot of medications and things. And then typically at the end. So we have an AI tool that can kind of predict death to about 95% accuracy for the last 12 days. And so it reads all of my nurses' notes. It reads our charts and says, based off this, here are the patients that they determine critical. And when a patient hits the critical bucket, it's like 96% accurate at predicting death within the next 7 to 12 days. But that's the other part of where it's expensive to care for patients, because when they hit those levels, what we want to do is send a nurse out every single day, because this is where things can get squirrely, right? You're starting to see, changes. People panic, they call 911, they send patients to the hospital. So again, our goal is to try to minimize that. And so we send out staff every single day, and that's when we feel like they're approaching death. And so to your question, if you have a lot of patients that have short length of stay, you're probably spending a lot more than you're earning. But if you have patients who live a little longer, it starts to balance out. Any other questions about that? So go back to hospice now a little bit. Again, it comes from the Latin root of hospitality, really. Our focus is really quality over quantity of life. And so in theory, when you do sign up for hospice, you are waiving your desire to pursue aggressive care. And what I mean by that is like active treatment for things, or like aggressive interventions of like, I want CPR, I want aggressive things like that. It doesn't mean that you have to be a DNR to enroll into hospice. We have plenty of patients who are full codes. And I guess that might be a good topic to talk about at this point, but okay. And so, there are plenty of things that are reversible. So we want to treat stuff that is reversible. I mean, if you have a simple UTI and you're under hospice, it's not like, oh, no, that's aggressive treatment. We don't treat that. No, if that's a reversible situation, we want to treat that. But, we also aren't looking to do active chemotherapy for a cancer patient under hospice care. Those two things typically don't go hand in hand. This is more of kind of the hospice philosophy, right? Like we don't hasten death, we don't postpone death. And so that is typically a myth that a lot of folks have about hospice, is that, once you enroll in hospice, everybody kind of gives up on you and you get morphine and Ativan and it's kind of quick. That's really not it at all. We don't try to prolong life, but we also certainly don't try to shorten life either. We have that whole team, right? And I think this is the big takeaway too, is that, it's more than just medical care with hospice. We have psychosocial support, we have spiritual support, you've got volunteer support, you've got all kinds of other things. And it's not just about the patient, but it's about the whole family unit when you enroll in a hospice that we're supporting and caring for. That's boring stuff. He'll talk about that next one. Like, not that your stuff is boring, but how hospice is paid and, all of those things. I will say, so just to kind of put a point on this though, like, who's in charge of your decision making? Do you know who is the first person we would check with when it comes to decision making? Yourself, right? The patient. But what if you can't speak for yourself? Does anybody know the order of operations there?
Spouse.
It may not be a spouse. If you have a healthcare power of attorney, that is that would be number 2, would be healthcare power of attorney. So if you can't make a decision for yourself and you have a healthcare power of attorney, that person would be first in line to speak for you. And then it goes to legal guardian, and then a general kind of power of attorney, but there has to be some healthcare delineations there. It can't just be like a financial POA. And then you get into the spouse or the children or sometimes you have children that don't all agree. So it's usually the majority of the adults, children. So there is actually there's a work list that we would go through in terms of who is authorized to make decisions here. And oftentimes during the course of care, it changes quite a bit.
We'll talk about the importance of that in a minute.
But it also ties into the payment piece as well, and making sure that your financial house is in order. And that's something that our social workers do a lot of helping folks do and get things in place. Even down to like, who's going to take care of your pets if you're by yourself. So again, the benefit is it's inclusive. It covers a lot of stuff. You're getting physician visits, you're getting nursing visits, you're getting CNA, social workers, chaplains, volunteers, pharmacists to review, you're getting bereavement counseling, sometimes in advance, because we do anticipatory brief. We pay for the meds, the DME, the O2, the supplies, all the OT, whatever else that might be beneficial or needed, all of that comes out of that $200 a day. And you don't pay anything for it when you enroll in hospice through Medicare. So the biggest thing here that I wanted to highlight on this slide really is that, again, a DNR is not a requirement to get enrolled into hospice. It can complicate things a little bit if you're not, but it is not a requirement. And again, I find oftentimes we say yes to patients who want aggressive treatment or are full codes, knowing that once you start working with that hospice team for a couple weeks and we start pulling in the decision makers, sometimes the family members, getting everybody on the same page, eventually folks get together and say, you know what? Mom doesn't want to go to the hospital anymore. And that's what I want, but that's not necessarily what mom wants. And so we oftentimes are very successful in just kind of highlighting the path of this is where we eventually want to go, and getting everybody on the same page that before our involvement was kind of a little bit of chaos. So some of the most common disease states, again, cancer used to be our biggest diagnosis category with a lot of the advances in cancer treatment. It's really shrunk down to about 25% of our patient population is cancer. The biggest one these days are the neurological disorders. So dementia is a huge one, and all of those kind of subtypes. So ALS, which is a brutal disease, Huntington's, Parkinson's, all of those kind of neurological diseases are by a group probably the number one reason for hospice admission in the country today. Then you've got COPD, you've got CHF, liver failure, renal failure. HIV was a big one in the 80s and 90s. We don't do a lot of HIV admissions anymore. If folks take their antiretrovirals correctly, it's really more of a chronic illness now. And so we have very few HIV patients today. And then protein calorie malnutrition is kind of like this bucket where, like, if you don't fit anything else, but, you know, we've all seen the little old lady who's, 80 pounds, and it's like, how is she still around? We typically admit under protein calorie malnutrition because they may not have any of those other diagnoses, but they're not a picture of health and they're losing weight. So just a couple other things about the hospice benefit. Routine home care is what most people get, and that's the delivery of care in their home or in facilities like an AL or even a SNF, skilled nursing facility. GIP is the one you might think about for the hospice house. So if you've ever had a loved one or know of people who've gone into like a hospice inpatient unit, that is a higher level of care, and you have to qualify for that. So it is when the symptom or a situation can't be managed in their current location. And so typically that's usually like a pain or a shortness of breath or some kind of symptom management issue. Then you go into the hospice house, and that's typically where you get, we staff with 24-hour RNs. You're in a 16 or 12 bed facility. And it's short term, usually like 5 days or less. Respite care. So part of the hospice benefit is interesting that I don't think a lot of people know too, is when you're under hospice care, there is a respite benefit for caregiver burnout. It takes a lot to care for folks, especially folks who are dying. And so if you have a caregiving burnout situation, you can get 5 days of respite covered as part of that. So we would typically, for us, we would put your loved one in one of our hospice houses at the respite level of care and allow you to get a little bit of a break as a caregiver. Crisis care used to be a little bit more where like the nurse would stay for 8 to 24 hours in the home continuously. But with the advent of hospice houses, not a lot of people do continuous care anymore. And so that's just some pictures of the hospice units we have up in Huntersville, Alders Gate, Southminster. They're very beautiful, peaceful buildings. Very different experience dying here versus dying in a hospital setting with the bells and other stuff going on. Very, very different experience.
Are they typically within the context of another facility, a wider facility?
Some are, so that picture in the top right is the one in Huntersville, and that's a kind of a standalone building. The other ones in Southminster and Aldersgate, those two pictures on the bottom right, we actually lease a wing out of those CCRCs. But they're contained units, so they feel separate. You get to eat Southminster cooked food, which is pretty nice when you're there.
You don't have to be a resident of Southminster.
You do not, no. You have to be a hospice patient, but you don't have to be a resident of those locations.
I've heard great compliments about the one in Huntersville.
Oh, well, thank you. Yeah, that's our oldest building. Actually, when I got hired is when that was opened. And so that is our longest standing unit. And it's a beautiful place. If you've never been there. If anybody's interested in volunteering for hospice is a wonderful thing to do as well. And it doesn't have to be, if you're not comfortable with bedside kind of things, there's a lot of other things you can help with. It's like hospice.
Do you all train volunteers?
We do.
Yeah. Like church groups send in volunteers or just more individuals?
I'll tell you, it's a little bit of a pain to be a volunteer because of Medicare, we have to kind of consider you like an employee, which means you have to do like a certain amount of education every year. And so it's not as easy as just showing up. There is a little bit of a process, but once you get through that, we have volunteers who call our home patients once a week, every Thursday morning, just to check in and say hello and make sure they have what they need for the weekend. Or we have people that round at the units playing music, bring their pets, like all kinds of stuff. And then we do a grief camp for kids once a year. We had over, I think it was 110 kids at the last Chameleon's Journey in October down at Camp Thunderbird in Lake Wiley. And so this is for any child who's had a loss, like immediate family, grandparent, whatever, like they come and it's all free. So this is another great opportunity for volunteers and other things. So advanced directives.
Yeah, I put these slides together, so I'm gonna come over here so you can see, and Michael, you don't have to go anywhere. So we just wanted to spend a minute on advanced directives, and just the simple definition is that they are a variety of legal documents that allow individuals to state their wishes about their medical care, finances, and property, in case they can't communicate their preferences because they become incapacitated or have died. And there are some of these resources on the Passages website. Also, Atrium Healthcare has a great section on this if you are looking for some documents. So what are the most common types of advanced directives? You all could probably name some of them. A living will describes when you would want certain medical care withheld if you're unable to speak for yourself. Durable power of attorney states who can handle your financial matters and make related decisions on your behalf if you're unable to do so. And this, of course, only is in effect while you're alive. Healthcare power of attorney allows another person to make medical decisions for you if you're unable to make those decisions for yourself. There's now an advance instruction for mental health that outlines preferences for mental health treatments, such as electroshock therapy or medication. And then a will is perhaps one of our primary advanced directives. We don't always think about it that way, but it certainly is giving information about who would receive your property and who handles your affairs upon death. So when should we prepare advanced directives? Ken said yesterday, which is exactly the right answer. I know I didn't look and see everybody's hand raised, but I know a lot of you have done this, and it's so very important. We're going to talk about why.
I don't know if you cover most forms. Do you have most forms in here?
A lot of the forms are through those websites, yes.
So the most form in North Carolina is medical orders for scope of treatment. And so that is something that you can fill out with your physician. So historically people think about, am I a DNR? Am I not a DNR? Well, it doesn't have to be that black and white. So what the most
DNR is do not resuscitate.
Sorry. And so I can tell you stories about DNRs and what my old physician CMO used to talk about that, but you know, CPR and TV is not how it goes. And I'm sure you all know that, but most forms are kind of almost like a curated group of decisions. So like you may want ventilation, but you don't want artificial nutrition. Or you may want to do antibiotics, but you don't want to do something else. And so there's a whole list of things that you can choose and say, yeah, I want that. No, I don't want that. It's more like a la carte than just I want to be resuscitated or I don't want to be resuscitated. But you do need a physician to sign off on that. And so that's why it's called a medical order for scope of treatment. And so it has to be on like a certain colored piece of paper as well to be approved and viewed as legitimate. But that's in North Carolina, it's called the most. And then I think South Carolina, for anybody that lives in South Carolina, I think it's called a POLST, a physician order for something scope of treatment.
Well
So
done.
Does that include a DNR?
there is a checkbox for DNR on that as well. So yeah, so it's all encompassing, but it's also gives you a lot more options of like, yes, I want that or no.
So it just says advanced directives can only be authorized at a time when we have the legal capacity to make decisions and appoint others to handle things for us. Once we lose the mental or physical ability to make and communicate decisions, we also lose the ability to create valid, enforceable powers of attorney. So why are they so important? We just don't have the ability to predict the future, but we can prepare for the future. And this makes all the difference. There are wonderful, wonderful stories about these documents working well. I know a lot of you know Kim Staney from our congregation. She was in a car accident. When I went to visit her, all she could say is, I'm so glad I had all the advanced directives, power of attorney for my sister, healthcare power, so that as she was in bed after a very challenging accident, everything went fine because she had already designated someone to take care of all of that. And it made all the difference. So you don't know, it's not necessarily that it's going to be, oh, I'm approaching my end of life. It could be that you're in an accident and you really can't get out of the hospital bed or something else. So it's really about just being prepared for any situation that might come up. And there's some terrible stories about what happens when the documents are not available and people's preferences are unknown or the information is outdated. I know personally, I grew up and my parents' wills were terribly outdated and it just created the biggest mess. And so that's true too for any of these other kinds of directives. So where should they be kept? I think one of the most important things is not just that you have the advanced directives, but people know you have them and know where they are. And even more than that, that you take the time to talk with your loved ones about your wishes. And this is challenging because this means that at some point we have to consider that we're not always going to be here, that we're not always going to be at full capacity. And that is not easy. But I think what I would impress upon you is the risks of not doing that are so much greater. And one of the most consistent things that we see as ministers is when adult children are not kept in the same loop. And typically it's the one who's way off, if you live in North Carolina, it's the one way off in California. They're busy with their life. They don't get home much. Things begin to change at home, and they haven't been a part of that. They haven't been a part of the communication. They don't know what's going on. Another sibling has been in the day-to-day care, and they come in and they're way behind the 8 ball. They're trying to catch up emotionally. They're trying to catch up intellectually, and it usually wreaks havoc on everything because they're demanding things that make sense to them, but make no sense to no one else who's in the loop. So again, I just really encourage you not only to do the directives, but really to take the time to bring everybody who needs to into the loop. Because it's really, really difficult when these are done this way. So have the file very handy and have whoever's around, know where that file is. The sister of Kim knew where to find it and how to get there, and everything was updated. And that's the other thing, update them regularly.
A very wise attorney told me once to buy a fireproof, waterproof safe for your house.
I love that.
To put those originals
And who are you giving the code to?
in. I don't like mine.
Okay. Okay, so there you go. It's about having something that will survive, that everybody knows where it is.
Mary, I just want to follow up a little bit with
Our attorney in the room.
this is just a practical thing. A lot of people put them in their bank safety deposit boxes. And then when somebody's passed, the bank knows about it. They're not gonna give you access to that box. And you go down to the clerk's office, it's simple, but it's another step. And you get an order to open the safety deposit box, and then once then you drill it, or whatever the case may be. What I tell people, if somebody passes, don't tell anybody at the bank about it. Go in, open the safety deposit box, and clean it out. And then you've got the will, you've got, if they put it there, you've also got other assets that you might want to remove.
Would it make more sense to keep the will at your house?
I was just gonna say, even better is let that be a copy and have another copy at home and in the safe, in the red folder, right by the phone in the
But
kitchen.
on the copy, you have to have the original will.
Okay.
Copy will not do. You can probably administer a copy, yes, but then you have to go through a separate process to
Should you have a couple of copies
oh yeah, you can have a million copies.
of that, so that person A is unavailable, but person B knows this is what Ann wants when she passes?
But you can use copies of powers of attorney and things like that, but you've got to have that original will. So.
And what we're particularly interested is less the will right now, as if you're incapacitated and someone else is making decisions for you, do they know where to find? So the will is critical and so helpful. I appreciate your perspective.
And then again, where you put it brings up, because I do a bit of litigation related to it. A child that's left out, for example, gets into the will first.
Right.
And the person dies of testing, so it goes to heirs, everybody receives equally. You have a lot of that kind of stuff, so, keeping the original will safe. And if you're treating people differently in some way, which happens a lot. I had a doctor and spent a fortune on this drug addicted, alcohol related son, and so in his will, nice big paragraph about I love you very much, but I have spent your part of the inheritance, $500,000 worth of treatments and something else, so you're getting only this. Other son got that. So yeah. Just be careful with it.
But does it like if you keep it safe? The suggestion seems to be is have it in a fireproof, waterproof box at home as opposed to the box at the bank.
I have heard, and I don't know if this is a good idea, to put it in the freezer. I don't know if that's a good idea.
We've told people that in the past, it's ice in case of emergency, go to the ice box. But
What if it leaks?
when we,
That's where you put the body.
when we have patients under hospice, we typically tell them to put their advanced directives like on the fridge, where it's very visible. Because again, to Mary's point, like if something happens, there you go, right on cue. If something happens and the son from California is sitting with mom now, instead of the daughter who's usually there, and they call 911. If there's not clear documentation of what to do, not like medic is obligated to, you know, unless proven otherwise, they have to take action. And so without that kind of easily seen and known, they're going to be obligated to act upon whatever they got called out there for, and probably take the patient to the hospital. And that includes chest compressions, all that kind of stuff. And so if that, you know, communication is key. It solves 95% of the world's problems. You got to let folks know where your stuff is, what your wishes are, how to access them, where to find them. And, you know, an ounce of prevention goes a long way.
One other thing too, with the declaration of a desire for a natural death, the living will. We've had this situation come up from time to time. The beauty of that instrument is that you are signing it for yourself when you're competent. So when the kids are sitting around and dad lets mom go, and some of the kids are saying, you know, you killed her. You didn't have to do it. You killed her so you could do this, or no, I didn't do that. She executed that, and that's what she wanted. I just fulfilled her wishes. I had no part in it other than to make sure her wishes were carried out.
Right.
And that's just something I tell folks to tell their kids or their spouse or something that this is what I want. And I've had young people refuse to sign.
Yeah.
Kelly, I don't know, maybe we're on and moving past our time, so maybe you can allow just a little more conversation next week on this. But I mean, I will tell you, there are heartbreaking stories of people waiting too long, and mom slips into dementia and out of the ability to be perceived as competently making decisions. And it would have been so much nicer if all that had been done ahead of time. And again, do it in the next month and then review it each year. You can change your mind. It's not that, you know, it sets it in stone for you, but at some point of reference and access to you, if you are not, for some reason, you're in a car accident or something else, and people need to make decisions for you, even just financially, right? That power of attorney, so they can pay the bills for you while you're in the hospital or something else. So again, we can't predict, but we can prepare, and it's just really hard to overstate how important that really is. Can you join me in thanking Michael for? I got to know Michael when we were both he's still at Selwyn Avenue Presbyterian. I got to know him there, and so really appreciate you joining us. And you can linger maybe for questions, if that's okay. And then others, if you want to get on to worship. Thank you so much for joining us.
You guys said he's not walking. It's weird what you've done for longer.
We don't hear about that stuff.